So I think with whatever time is left now, I would just like to highlight and showcase one or two videos. So whenever we have a decentered bag IOL complex, the most common problem that comes up is the vitreous bulge. So we have had lots of talks on, putting up the devices and how to go ahead, fixing up with the Gore-Tex and, having a three-piece IOL and everything. So I would just highlight one or two videos right now that how we need to take care of the vitreous bulge around the subluxations. Now this is a video. This shows how, this is a case, where there is a segment where there is an absence of zonules. And now when you actually start doing capsulorhexis in these cases, and when you start doing a phacoemulsification, what actually happens is that, the fluid of the phacoemulsification, it actually goes around the lens from the communication which is there between the anterior and the posterior segment. So what happens is that, you are hydrating the vitreous at every point of time while you're doing a phacoemulsification. So what actually might happen during this is that, with the vitreous hydration coming up, you might have a bulge coming up from that area, and it manifests as shallowing of the anterior chamber when you take up these cases, when you have subluxations or you have colobomas, etc. So in these situations, it's a small practical tip that I usually adopt, and which we have described as a vitrectomy-assisted phacoemulsification. You just put a trocar in the area of dehiscence, and from there, what you can actually do is a dry vitrectomy. So what actually happens is that, you are debulking the vitreous from there. You need not put a fluid infusion because already there is so much of fluid behind. And it's a very limited amount of dry vitrectomy that you actually do, and then it leads to deepening of the anterior chamber, and then you can go ahead and do your phacoemulsification procedure. So this is one method by which, you can actually control the bulge of the vitreous that comes around. The only clinical tip here is that, when you put the vitrectomy probe, you should be seeing the tip of the vitrectomy probe. You should actually not cut the posterior capsule accidentally with the tip of the vitrectomy probe. So that is a very important thing, where to actually put the trocar and the vitrectomy probe. You have to put it in the area of the dehiscence so that you actually keep on seeing it. Now this procedure, it can be repeated as many times. It depends upon the length of the surgery, the density of the cataract, and maybe you might just need it once, or you might need it even twice or thrice. So you can do it as many times as you feel it is necessary during the surgery. And then, you can just stabilize this capsular bag with the CTR being placed. One of the clinical tip is that, now there are different types of CTRs also available. Many times what happens is that, CTRs, they might tend to hold onto the cortical matter which is present in the periphery, and then it becomes actually difficult to remove that cortical matter, as Dr. Chang showed in one of the videos. So these are the cases where, I actually like to take a three-piece intraocular lens and go ahead. The reason being that, if there is any change, or if there is any vitreous popping up, or if there is any new condition that develops while doing the surgery, the same intraocular lens can be used, and you can be intraocular fixation can be done with this IOL. So here, this is just that you are just closing up the pupillary defect, and we're trying to finish up this case with this. So this was the vitrectomy assisted phacoemulsification, which actually becomes very helpful in some of the cases. This is the second case. Again, you have a light subluxation out there. Now there are cases where, some of the surgeons, we like to use capsular hooks. Some of the surgeons, and even the timing of placing the capsular hook is also very important. Usually we try to do it after the capsulorhexis that is placed, but in this case what actually happened was that as soon as the capsulorhexis and hydrodissection was done, the entire nucleus came up into the anterior chamber. So like it was something like you are doing a phacoemulsification in the anterior chamber. So once this nucleus is totally emulsified, you can just see that yes, there is a small, dehiscence, an area of dehiscence in one of the quadrants, and you have to be very careful when you're doing irrigation aspiration in that area. Lucky enough that, you are still seeing that there is a dehiscence which is there in that area, and you could get away by not using capsular hook, but it is very much essential to, place up the capsular tension ring, and so that it totally holds it back. Now this was a traumatic case. It was not a case of a progressive zonulopathy. So you can just place a CTR, and you can see how stable the intraocular lens is after doing this surgical procedure. Now in this case, what you actually see is that even after placing this, and when you are doing an IA, you again see that, oh, there is a decentration. So now this, you cannot leave it as such on the table. you need to take up this case and you need to kill the bulge which is coming from behind. So once you do that, with the pars plana vitrectomy, be very careful of when you do this, because you might damage the posterior capsule. You have to be very careful, very diligently you do it. You shave off the vitreous, and then you see how beautiful it actually remains into its position. Scleral flaps were made for this case initially because we were not sure if the lens would decenter and we would not be able, maybe we might have to do a glue dal, but nothing had to be done for this case, and the flaps were just sealed because they were made initially anticipating that there might be some problem coming up during the surgery, but it actually did not happen. I think we're running short of time, so I'll just show this small clip which I want everybody to emphasize. We always we have these capsular segment placed inside the eye. So capsular segment protrusion can occur. Why would a capsular segment protrusion occur? For example, you see this clinical case which is there. This case had an endocapsular segment. There was a 3-piece IOL. There was an endocapsular ring also inside this eye, and still the intraocular lens here was, it was shaking after a history of maybe 5 to 7 years of surgery. Leave aside everything. This was a complication which occurred, and it's altogether a different issue. But what I'm trying to highlight here is the fact that this is an endocapsular segment which was placed inside the bag, and there is a degradation of the suture here. Now, this degradation of the suture does not hold the capsular bag into its position, and maybe because of this, there was a shaking of the capsular bag IOL complex, and that is why this patient, which was initially operated, had the lady, she had a pseudo exfoliation, and then this segment was placed, and just because the segment did not hold it into place because of the suture degradation, the bag was not stable. So this important aspect has to be taken into consideration. And anyway, for this case, we had to remove the endocapsular segment totally. So another important thing that we need to take care of is that, when you place the capsular tension segment, it should be placed into a proper plane, properly sutured. And initially, I think maybe some of the surgeons, they also used a Tenno suture, but we do not recommend using a Tenno suture because now we have newer techniques. And we also saw Dr. Chi, she showed us, how beautifully Gore-Tex can be used and how it can be sutured into its place. Surgeons now, they're also using the Prolene suture, the 6-Prolene suture, making flanges and fixating up. So these are some of the important things to be taken into consideration whenever we have a subluxation. I think I need to wind up because we're running short of time. Thank you so much, everybody, for being here.